Good afternoon, everybody. Welcome to week 6 of Retention Academy. So if you're counting and looking at your calendar, we have made it to the halfway mark of this cohort. I just can't believe it. We are hoping that you are settling into your routine of Wednesday afternoons with us and enjoying the journey so far. I'm Suzanne Spear, and I am joined here at ACU by Ann Hogan and Mariah Blake. We're thrilled to once again this week welcome some guest faculty for our webinar. Today we have Jeremy Make from HITEQ to talk to us today about the role of EHR and provider burnout. Thanks so much, Jeremy, for joining us. And just before we get started, just a few housekeeping items to address. We are recording this webinar and it will be posted on the discussion board later today if you'd like to go back and listen to it again. And second, feel free to ask questions along the way and let's have some fun. Why don't we? So if you do have a question, use the raise your hand tool and the control bar on the right side of the screen to alert our team that you have a question. You can also use the chat or questions box in the control bar to send your question to us, and we'll direct them to Jeremy at the end of the presentation for an answer. If you think of a question after this webinar or would like to follow up for more information, feel free to email Mariah Blake at mblake@clinicians.org, and also feel free to contact her should you be having any technical difficulties. We will reserve a few minutes at the end for questions, but if we aren't able to answer them all today, we'll take note of them and then answer them during next week's office hour. That happened last week, and we were glad to have some additional time during the office hour to answer those questions. So with that, I'll hand it over to Jeremy with HITEQ, and he can take it away.
Thank you so much, Suzanne, and welcome everyone. Thank you for joining us today. I'm really looking forward to discussing impediments to joy related to EMR or EHR use. I just wanted to start by thanking Suzanne for coordinating all the details, and then as well my colleague Natalie should be on the line. Her important work with HITEQ is really has been really valuable, so thank you. Natalie's also going to back me up here and help answer any questions that she knows much more about than I do, I'm sure. But she is currently driving through a nor'easter while I'm sitting at my computer in 70-degree weather in Colorado. So please be careful, Natalie, and thanks everyone for joining and being on the call. So let's start by talking about HITEQ. The HITEQ Center is funded by HRSA. It's a cooperative agreement with our partners, and the partners include PCAs and HCCNs and other national cooperative agreements, and we're just supporting health centers in their use of EHRs and other health IT systems. You know, I think the ultimate goal of HITEQ is to really help drive continuous data-driven quality improvement. HITEQ services, we have quite a few main services. They include development and ongoing updates to a web-based health IT knowledge base, conducting workshops and webinars, and providing targeted technical assistance. You'll see here on the screen there are 10 main focus areas. So QI, choosing and implementing an EHR, HIEs, meaningful use, workforce development, value-based payments, privacy and security, patient engagement, and population health. So, you know, I watched the Retention Academy webinar on team-based care from a couple weeks ago, and then the homework assignment from last week. And everyone had such good questions, so I'm hoping that you'll have some for us as well as we're going. Please feel free to chat them and stop me, Suzanne, if you see them before I do. That session was really, really great. And I think our discussion today follows softly upon, I'm bastardizing Hamlet here. Horatio says, "Indeed, my lord, it followed hard upon." I think our session follows more nicely upon the team-based care. So let's talk provider satisfaction for a moment, shall we? So too often it seems that we jump to the language of burnout first, but I really want to flip the script and talk a little more about joy first. Or more accurately, I think something along the lines of meaningfulness, because medicine isn't always joyful, right? It can be difficult, but in many cases it can be more fulfilling and more meaningful than it is. So ask any provider why they got into medicine, and we can all guess at what their answer is or was. I want to help people. I just want to see patients. They often say that when they're asked to make a change to a workflow or add an additional documentation step. And they're not just saying that because they don't want to make a change. They really mean it, right? I got into medicine because I want to help patients lead a healthy lifestyle, not because I wanted to click through 100 computer screens to do that. And I think we can all sympathize as leaders in your organizations, as consultants. We know that the work that they're doing is just trying to help patients. But let's start to empathize a bit here instead of just sympathizing. So over the last few weeks, we did a literature review, and we conducted a few key informant interviews, I guess you could call them, to prepare for the webinar. And I always started by asking what providers found most valuable about their EHR. Not necessarily what are you most stressed about, right? Or what's contributing to your documentation time, or what's not working for you. I always started with what's working for you. And we got some really great answers. And then the literature had a couple to add as well. They said we like e-prescribing. They said we like the ease of reviewing patient information and sharing records and labs. It's nice to be able to do medication and allergy checks from a patient record. Labs and test results get incorporated nicely. So I want to hone in on this screen and say, look, everyone, here's our proof. Here's our proof that EMRs are not the worst invention of the modern era. And this is really the reason that EHRs were created, right? The point was to make life easier, to make it more efficient, to provide some relief so that there wasn't so much hand charting or dictating every word of a patient's file, for example. And in plenty of cases, EHRs did exactly that. They helped. But as with many new technologies, there were problems. Here are some of the problems that occurred when EHRs didn't work the way that they were intended. Providers lost their even balance between work and home life. Their satisfaction dwindled, along with patient satisfaction. They missed out on spending time with patients and had to reduce the number of visits they could complete in a day. And when they were able to see patients, their focus often moved to screens and away from, from eyeballs and caring hands on patients. Their documentation time went up, like way up. 2 hours of time spent charting for every 1 hour of patient time that's face-to-face or face-to-screen in some cases. And most of that extra time was spent at home, with an average of, in some cases, more than 2 hours of work after hours. In one study I saw, residents spent nearly 4 hours completing their documentation after they finished the already long workday. So it's no wonder that the burnout rate is hovering around 50%, or in some cases much higher. Attrition was high, turnover was inevitable. You may have noticed that I'm using the past tense here very purposefully. I'll explain why in a moment, but first, one more reason to care that I think will make you see stars or dollar signs or lack of dollar signs. So there was this article in 2012 posted on the website for the Association of Staff Physician Recruiters. This woman, Lori, I think it's pronounced Shute. She studied data from the 2 or 3 years before to estimate the cost of losing and then having to replace a provider. So she broke it down for a 6-month vacancy and then the 12-month vacancy. So the top number on the far right, you see that almost $500,000 is the lost revenue from a 6-month provider vacancy. That's only 6 months. You can see in the middle, right, nearly $1 million for a year of lost revenue. Once you add in the recruiting costs and interview time and a signing bonus and moving expenses, not to mention the onboarding time and the resources it takes to get someone trained up, we're talking well over $750,000 for a 6-month vacancy, and then significantly more than $1 million for a full year vacancy. Now, the author was really just trying to make this point about inefficient recruitment and hiring practices, but she just happened to hit on a really important factor for executive leaders in healthcare, which is the money factor. So $1.2 million, as you are well aware, is a tremendous amount of money, and that was in 2012. So with inflation, that's somewhere along the lines of $3 billion. If someone can check my math, that would be great. So on the ground, we heard from providers about some of their personal struggles in their own words. And a reminder here that the first question I asked was about provider satisfaction related to EHR use. I didn't start with this question of what's your biggest frustration with your EHR, but we did ask it, and here are some of the responses we got. So top left, you'll see it takes away from interpersonal time with patients. I'm a communication junkie, so that one really, really bothers me. The top middle one, I'm using 2 EHRs at the same time because they didn't migrate the data. The bottom right, I'm using 6 different systems. So granted, some of these responses are from specialists, surgeons and hospitalists and folks, but I also spoke with pediatricians and internal medicine providers, and the responses were very similar. And some of these represent those responses. What's interesting about all of these responses, though, is there are 2 main takeaways for me. Okay, so the first one, many of these frustrations are not about the EMR in and of itself, per se. They're more about the process of integrating the use of a computer into an innately hands-on and face-to-face interaction. So that was interesting. Second, these are solvable, right? I mean, look at these responses. Like that top middle one is basically saying, just put it together, right? Someone is making this person switch between, the PM system and the EMR potentially, or there's some issue there, like the information from the old EMR didn't get migrated into the new one or something. This could be something that's really easy to fix if the health IT team just took the time to work on it. So what do you lose when you don't take that time to combat the problems and overcome the barriers? You lose providers and money, and you're contributing to a culture in the organization that doesn't value staff feedback, provider feedback, and satisfaction. All those things lead to bad patient care, right? Worse outcomes, lower patient survey scores, and even safety issues or lawsuits in some cases. There's plenty of research about the malpractice suits that come from the lack of both provider and patient satisfaction. So that's the past. That's the stuff that we didn't address. Those are the complaints from before, right? So that's why I was talking about the past tense. But this is today, and you now have the chance to work on these issues and improve them, not just improving patient outcomes, but really improving the staff and provider outcomes too, reducing the burnout rate, getting more providers into the system, and not burning them out before they've even had a chance to be in practice. Okay, so before I introduce the next slide is about solutions. And you're gonna see 3 boxes that outline some possible solutions broken into these 3 main buckets or categories. So I'm calling the categories, the buckets, interface solutions, process-oriented solutions, and then personnel changes. Before I click to the next slide, the first thing I hope you notice is the sheer number of solutions I came up with just based on my research. It's a long list, and it's not even remotely comprehensive. These are the possible solutions for dealing with provider burnout because of EMR use. So when I switch to the next slide, you'll notice that I've bolded a couple key key opportunities in each of the buckets so that you can, and some of these are really quick and painless ways of making your EMR workflows for providers even better. Notice I didn't say perfect. I prefer the language of even better, right? What can I do to be even better in this webinar, for example? It's a good way of soliciting feedback, rather than just saying, what can I fix? Or what's wrong that you want changed? I know I'm doing a pretty good job, so what's it gonna take to make it even better for you? I'm sorry, I told you I was a communication nerd. Okay, so next slide. Okay, so these are the solution buckets. So let's start over on the far left with the interface solutions. I bolded 2 of them. All right, so there's the single sign-on, and this is a good one that kind of gets at all the other ones. But if you can provide a single login screen that has a very simple username and password combination, doesn't need to be changed every 3 months or every 3 minutes, right? You're right on track. So I should mention, by the way, there's a fair bit of research out about required frequent password changes that actually make that practice much more problematic than safety ensuring. Anyway, side note. So the one login screen for access to every other app or software you need is a nice possible solution. Worst case scenario is you're using the same login information, but for multiple screens. If you're on the same IP network, though, that's not really an excuse to use. You can do this. IT can do this. So one sign-on screen. Another one, easier access to other apps. Again, that's sort of the single login that can help with that. One thing you can learn from providers is how many apps or tabs they have to toggle between. So we know already a lot about click fatigue and how destructive that is, but switching between multiple programs and multiple tabs can be just as frustrating, even though it's not a ton of clicks between each. All right, so processes, that middle bucket. Many of these are about working with your vendor, which means working with your IT staff, which means asking providers about what they're looking for, being part of the solution. On the next slide, we'll talk a little more about how to do that. But for now, know that as leaders of your health centers, there's only so much that you can do. It really does take a combined effort from almost everyone at the organization to get this right, and then speaking with vendors as well. So bullet 2 in the processes bucket, figuring out the best practices, trying to align workflows based on white papers, working with that vendor, collaborating with providers and IT to come up with good solutions. That last bullet then in the processes, just carve out time during work hours. I want to encourage you to stop sort of passively accepting that providers are going to take work home with them. Insist on work staying at work. This is kind of a last resort option, but it's not a terrible one. When I have secure, protected time to catch up on emails, say once a month, that feeling of accomplishment afterwards is really huge, and it does provide a real stress relief for me. So we can all bet that that's the case for providers as well. I wish I could say there's like a standard amount of catch-up time that you should build into provider schedules, but I can't. The first reason I can't is because there isn't really a magic number. But second of all, it should be a conversation that you're having with providers to find out to find out their needs. So, trying to figure out like where's that catch point of too many patient visit slots getting eaten up by the documentation time and that protected time versus are providers spending so much time outside of work hours that they're completely overwhelmed and they're losing that work-life balance. So trying to find that catch point. Okay, and then finally is personnel, the green bucket on the right. If you have had your ears and eyes open at all in the last few years, you've probably heard the research about scribes. If you were blindfolded, let me break it down for you. Scribes are good, is what it comes down to. They increase patient satisfaction and provider satisfaction. They reduce burnout. They're inexpensive. You can often find people in clinical education programs who are willing to scribe for a short time to supplement their income while they're in school. So the research is almost entirely in favor of using scribes in clinical settings to help with problems. One of which is providers spending too much time documenting and not enough time speaking to and working with patients. So I get it, not all health centers have the budget to add a scribe, but if you've got an MA, you've got the ability to increase their scope of practice to include some scribe-like duties. And you don't even necessarily need a ratio of 2 MAs for every 1 provider. You can really do this with a 1-to-1 ratio. It's not a problem. So there's a little bit of upfront training necessary for those MAs to accurately capture what the provider needs captured in the EMR. But a week of training and a good close relationship between the MA and provider is really all it takes. And if you're pulling MAs from your MA pool anyway, they probably already have a good relationship with those providers. Next bullet down, number 3 on there in the personnel bucket list, I guess, is it's a good one. I think I read this one in one of the articles I cite at the end of the webinar. It's basically a suggestion to just filter out messages to and from patients that don't need to go to the provider. So it's possible that an RN can answer many questions or follow up on labs with patients. In many cases, front of home staff can do this. Front of home staff I call instead of front desk staff. Modeled after patient-centered medical homes. So those are just some of the solutions to EHR overwhelmed providers. Some take a little more time and a little more testing to implement. Others are pretty quick and can be inexpensive fixes. But these are kind of in a vacuum, right? Until you talk to providers, you don't really know specifically what their concerns are. So where's the better place to start? There we go. So here's one place to start. The Institute for Healthcare Improvement, IHI. So IHI has done a really great job of working on trying to achieve the quadruple aim in healthcare, right? Especially around the 4th aim, which is provider satisfaction. So IHI came up with this stair-step method for addressing employee satisfaction in healthcare. And I really, really like this model. It's clear, it's 4 steps. Maybe most importantly, it starts with joy in the workplace, not the impediments, because that's the 2nd step in the ladder. So this method is really designed with leadership in mind. So, as EDs, as CEOs, as presidents of your organizations, you're the ones best positioned to take on this task. Okay, so step 1, asking providers what's working, what's going right in the EMR. What does the EMR do that makes your job easier? You really want to start with this because knowing the strengths of your EMR might allow you to build on those strengths in interesting ways. So the focus on step 1 is really on listening. Document those satisfaction points before you ask about the pain points. And just make some protected time to hear from a few providers and you'll be off to a good start. Step 2, the one you've all been waiting for, what are the impediments to joy in your work? You can preface this question by explaining to providers that you may not be able to address every concern they have about the EHR, but you want to make space to hear those concerns at least, and you want to be able to tackle the ones over which you have the most control. There's really only one rule here, and it's an important one. Don't leave providers hanging. If they give you a list of problems, long or short, and you don't address any of them, or you don't keep them updated, keep the providers updated about, which ones you're working on, you're gonna have some angry providers on your staff. So that's step 3, that's the commitment. So be systematic, measure your gains or your losses.
Hi there. I'm not sure what happened. Jeremy, did we lose you? It looks like we might have lost Jeremy. So sorry about that. I'm not sure exactly what happened, but I do believe we were almost at the end of the session. So what we'll go ahead and do is to looks like if folks can hear me, will you just raise your hand if you can hear me? Okay, everybody can hear me. Okay, Jeremy, yes.
It looks like Jeremy lost his internet connection or something to do with that, so dropped off his audio on his end.
Okay.
He might be trying to get back in.
Okay, great. Well, it looks like we just have a few more minutes, so just wanted to, sorry about that, everybody, let folks know that the office hour, we're going to be having an office hour next week, and also talking about next week's assignment, and that is at 2 p.m. on March 21st. And it looks like we had a considerable number of questions come in. And so what we'll do is exactly like what we did last time, is we'll take note of those questions, because I know that this conversation has, a lot of conversation can be had around this topic. And so we definitely want to be able to do that. So what we'll do again is have Jeremy, will give him the list of questions, and then he will answer those on next week's webinar. And if you have any questions that you thought of after this presentation, feel free to email either Mariah or myself, and we will make sure that we get them answered during the office hour. And we'll also have some time to reveal the homework and then talk a little bit about that too. I also wanted to remind folks that I know last week's assignment there were surveys, but make sure that you are posting something about maybe a lesson learned from the survey that you did with your team, or questions that you had for someone else. This is kind of what we learned from the survey. Is anyone else hearing about that, or did anyone else learn that as well? Just so to do some peer sharing and make the most of the discussion board. And don't forget that you also have your accountability partners, so you can make use of them too. Again, thanks so much for joining us today. Apologies for the technical difficulties, and we look forward to talking to you guys next week. And again, we'll have Jeremy from HITEQ again with us and answer your questions and talk about the homework. Thanks so much, everybody. Have a great afternoon. Take care.